All right, for this session, the subject is Intra-Articular joint therapies. And we'll have 3 presentations, and please hold questions until after all 3. These veterinarians will discuss current changes in the regulations of corticosteroids, including threshold levels, new information pertaining to toxicity, and beneficial effects when used properly. First, we have Dr. Heather Knych, Assistant Professor of Clinical Molecular Biosciences at the University of California, Davis. Dr. Knych.
All right, thank you very much. One of our primary research focuses at the Maddie Lab at UC Davis is corticosteroid use in racehorses. And our research into corticosteroids was really kind of kick-started about 4.5 years ago when I was fortunate enough to receive a postdoctoral research fellowship from the RMTC. And during that time, we were able to complete a number of different studies. So what I thought I would do today was talk about some of those studies, some of the more significant findings, and how those relate to regulating the use of corticosteroids. And hopefully I won't bore you too much with too many graphs here. All right, so I think everyone's pretty familiar with most of the information on this slide, but I just wanted to put this up here as a starting point. Corticosteroids are very potent anti-inflammatory agents, and as such, we use them commonly in racehorses, or probably most performance horses for that matter. One of the benefits of corticosteroids, at least intra-articular corticosteroids, is that they are long-acting. This is a result both of the formulation and based on their mechanism of action. So with respect to formulation, a lot of these intra-articular corticosteroids are what we call ester formulations. So what that means is they have an ester group attached to the drug molecule. This makes these drugs pretty insoluble. So simply put, they stay in the joint for a longer period of time. And what that means is we have a longer duration of effect. With respect to the mechanism of action, we say they have a genomic mechanism of action, and that just simply means that they act on DNA. So when the ester group that I talked about earlier is cleaved, the molecule is free, the drug molecule is free to cross into the nucleus of the cell, and it binds to DNA. With respect to the inflammatory effects, it binds to both anti and pro-inflammatory genes. So these code for these inflammatory and inflammatory and anti-inflammatory cytokines. So corticosteroids bind to these. They upregulate the expression of anti-inflammatory genes and downregulate the expression of pro-inflammatory genes. And I'm going to come back to that in a little while when I talk about the effects of corticosteroids on gene expression with some of our research. So I just went through this on the other slide, but essentially corticosteroids decrease the production of pro-inflammatory mediators, and what that means is we can decrease the acute inflammatory effects and hopefully the long-term detrimental effects. So maybe decrease the progression towards osteoarthritis. So as beneficial as corticosteroids can be, as much as they are anti-inflammatories, we can also see detrimental effects. And I know we've talked a lot about the use of corticosteroids and masking an injury that might otherwise keep an animal from racing. But at the same time, repeated administration of these corticosteroids can actually be detrimental to the joint itself. So it can actually degrade joint components. And there was a couple of studies published, one back in 2001 and one in 2005, where the investigators showed that repeated administration of both methylprednisolone and triamcinolone led to cartilage degradation. And this was with repeated administration. So in this case, they gave 600 milligrams of methylpred 3 times over the course of 5 weeks. For triamcinolone, they gave 12 milligrams 3 times over the course of 5 weeks. So with that very frequent administration, what they saw was destruction of the different joint components. So again, we need to, judicious use of corticosteroids is warranted, even though we may need them to treat inflammation. So the first study that we completed was a pharmacokinetic study, and this study was done just simply to provide information that could then be used to make a regulatory recommendation. So for this study, we used 16 exercised thoroughbred horses. So we have an exercised research herd at UC Davis, And we feel it's important to use exercised horses when we're trying to make recommendations for racehorses. So there's been studies, and they've shown with some drugs, that the distribution of the drugs as well as the clearance can be altered or can be different in sedentary versus exercised horses. So while admittedly our horses aren't as fit as a racehorse, we get as close as we can in a research setting. So we used 16 horses, 8 were mares, 8 were geldings. The age range was about 3 to 6 years of age. The doses we chose for the study was 9 milligrams of triamcinolone and 100 milligrams of methylpred. We administered that into the right antebrachiocarpal joint. Now, I've lumped both of these PK studies on one slide, but they were in fact 2 separate studies, and there was a very substantial washout period in between the 2 studies. We then collected blood, urine, and synovial fluid for measurement of drug concentrations. So these are the plasma curves for both triamcinolone and methylpred over time, post-administration. So on your left is the triamcinolone curve, and on your right is the methylprednisolone. Each individual line represents an individual horse, and the dotted line represents the recommended regulatory threshold. So in this case, it's 0.1 nanograms per mil or 100 picograms per mil. So what becomes apparent from these curves is that there is a great deal of variability between individual horses. So some horses obviously clear the drug faster than others. But you can see that all of these horses have cleared this drug fairly rapidly for triamcinolone and a little more prolonged for methylprednisolone. And with respect to the recommended withdrawal times, it's 7 days for triamcinolone and 21 days for methylpred. And what you can see from these 2 graphs is that the drug is completely cleared, it's below the recommended regulatory threshold by both of those times in all of these horses. Now, the actual withdrawal time recommendation builds in a bit of a safety factor. So that's just to account for the fact that not all horses are the same, that our population of research horses is not necessarily representative of every horse out there. So we use a statistical method to calculate in a safety factor to give a prolonged withdrawal time so as to avoid any positive findings. And we didn't do this research at UC Davis, but for betamethasone, we also have a 10 picogram per mil regulatory threshold, and that corresponds to 7 days, or 7-day withdrawal time. Okay, so these regulatory recommendations were based off of a single dose in a single joint. So at least in California, we had some concerns about whether this would actually apply to other doses administered, or if, for instance, multiple joints were used. So we organized a collaborative study between racetrack practitioners in Southern California and UC Davis. So I've listed a number of practitioners here who are kind enough to participate in this study. And it was organized at the racetrack by Dr. Jeff Blea and Dr. Rick Arthur. They kind of organized the collection of all of these samples. And this is the basic design of the study. So obviously the horses were horses that were actively racing. What we wanted to do with this study was study doses not previously studied and multiple intra-articular injections. So we did multiple joints. And then also looking at combinations of intra-articular corticosteroids. So the study was completely anonymous. The practitioner was responsible for assigning a sample number to each horse, so we had no idea which samples went with which horses or went with which practitioner for that matter. And all we asked was that the veterinarians record the dose that was administered, the drug that was administered, the joints that they administered the drug into, as well as manufacturer details. So we know there's a lot of compounded formulations out there, so we wanted to account for if perhaps we had an outlier, whether that was due to a compounded formulation or an FDA-approved product. We also asked that they record any information regarding corticosteroid use up to 60 days prior to commencement of this study, and then any additional corticosteroids administered throughout this study. So if, for instance, they gave triamcinolone intramuscularly, we wanted to know that because it could potentially affect our results. We asked that that blood samples, and then we looked at serum concentrations, be collected prior to drug administration, and then at 7, 10, 14, 17, 21, 28 days. And in the case of methylprednisolone, we asked for an additional sample at 35 days post-administration. So this is what we found, and you can see in that far left-hand column is the name of the corticosteroid. The 4 that we looked for were triamcinolone, methylpred, betamethasone, and isoflupridone. And we ran every single sample. We screened for all 4 of these drugs just because we have a screening method to look at all 4 at once, and it was just easier that way. In parentheses under the drug are the number of horses that we studied for that particular drug. And then in the second column is the dose that was given. So the top number represents the mean, and then the range is listed in parentheses there. So what's immediately obvious from this is that we had a huge range of concentrations. So for methylpred, we had 40 to 600 milligrams, for instance. And then on the subsequent columns, you can see the time that these concentrations fell, or the time that the blood samples fell below the RCI recommended threshold. So again, for triamcinolone, methylpred, and isoflupridone, it was 100 picograms per mil, and for betamethasone, it was 10. So for triamcinolone, all horses fell below that regulatory threshold by day 7. Okay, so all 17 horses. For methylprednisolone, we saw drug out for a longer period of time, as we would expect, but still, all horses had fallen below that threshold concentration, even at doses up to 600 milligrams by 21 days. So those 2 were well in keeping with the recommended withdrawal time. Isoflupridone was the same. All 7 horses were below that threshold by 7 days. Betamethasone, we had 7 of the 10 horses fall below the threshold by day 7. Now that is the recommended regulatory threshold. We had 3 horses at day 10, but I can tell you that the horses at day 10 corresponded to the higher doses of betamethasone, so closer to that 60 milligram. So in some cases, it may be necessary to add a little bit to the withdrawal time to avoid a positive regulatory finding. So another part of the pharmacokinetic study, we collected synovial fluid. So we were interested in knowing what the concentration of drug was in the synovial fluid. So one of the basic tenets of pharmacology is that the blood concentration tells you something about the concentration of drug at the effector site. But because these are essentially depot formulations, long-acting formulations, we were curious as to whether this really was the case. And there was actually a couple of studies published for triamcinolone that demonstrated this wasn't necessarily the case. So back in 1992, Chen and colleagues published a study showing detection of triamcinolone acetonide in synovial fluid at 15 days. And this is relative to 48 hours that they saw it in blood. Another study detected triamcinolone for 10 days, but only 5.5 days in blood. And I will say that for this particular study, 10 days was the last collection time, and drug was still detectable at that point. So we collected synovial fluid concentrations essentially till we could no longer find any drug. So the graph on your left is the plasma concentrations, the same as I showed on a previous slide. This time it's just the average concentrations. And the graph on the right represents the different synovial fluid concentrations. So the bottom cluster, and this is one thing I didn't mention previously, but we collected synovial fluid from the joint that we administered drug into, as well as the right middle carpal joint, and then from the same 2 joints on the left leg. So we were interested in seeing what the concentrations, if there were any, in those other joints. So the bottom cluster of lines represents the right middle carpal joint, and the top represents the right antebrachial carpal joint, so where we gave drug. As expected, the concentration in the joint that we put the drug into was much higher than the other one. But again, similar to the plasma concentrations, we can see a lot of variability between horses in terms of the detection of drug within the joint. But what you can see in the 1 horses, we have drug detected out to about 28 days. And in all cases, in all these horses, drug was detectable in the joint for an extended period of time relative to what we see in blood. So presumably, that duration of effect is still much prolonged, and dosing based on when they fall below the regulatory threshold is not necessarily necessary. We're still going to see an effect. So here's the same thing for methylpred. There was one study that I found that measured methylprednisolone concentrations in synovial fluid. There wasn't really any corresponding blood concentrations. But in this study, they detected methylprednisolone in the joint for about 5 to 39 days. Okay, so extended period of time in some, and again, highly variable. So again, our plasma concentration for methylpred is on the left, and the synovial fluid concentrations are on the right. The bottom cluster, again, represents that right middle carpal joint, and the top cluster, the right antebrachiocarpal joint. And again, great degree of variability, and we can detect drug concentrations in the synovial fluid for a very extended period of time. In one case, we had a horse that we detected out to 70 days post-administration. So methylprednisolone sticks around for a really long time, as a take-home point from this slide. We also collected from the left leg, I mentioned that previously, and we did actually, in the case of methylpred, different from triamcinolone, we did actually find drug in those two left joints. Now granted, they're low concentrations relative to the others, but we found it interesting that the drug must have gotten into the systemic circulation and then gotten over into that joint. Now, what this means pharmacologically, I don't really have an answer for you, whether it's an effective inflammatory or effective anti-inflammatory concentration still remains to be seen. But nonetheless, we saw drug in all 4 of these joints. All right, so I'm going to talk about another part of this study. We wanted to also look at gene expression. So I mentioned earlier that corticosteroids have a genomic mechanism of action, meaning they bind to DNA and they affect expression levels of different genes. And ultimately, this would presumably lead to protein production and differing levels of those different inflammatory and anti-inflammatory proteins. There has been some work done in this area, and it certainly has been done in human medicine. There was a study published in 2010 that looked at changes in gene expression in osteoarthritis and equine joints. So these are untreated joints. But I have a few inflammatory mediators listed below the study, and these are genes that were significantly changed with osteoarthritis or as the severity of osteoarthritis worsened. So these authors saw significant changes in TNF-alpha, matrix metalloproteinase 13, and a collagen gene. So this gave us a good starting point. If these change with osteoarthritis, perhaps we could assess how they change with corticosteroid administration. There was another study published in 2010 that looked in vitro at the effects of these 2 corticosteroids on inflammatory mediators and equine cartilage explants. And they saw significant changes in COX-2 and one of the matrix metalloproteinases. And I should mention that with both of these studies, as well as the third study, there were changes, I guess you would call them trends. So they did see differences in gene expression of different inflammatory mediators. They just weren't considered statistically significant. The ones I've listed up here are the ones that were statistically significant. So in the last study, this was an in vivo study where dexamethasone, another corticosteroid, was administered to rabbits. And what they did see was a decrease in some of these inflammatory genes. So all 3 of these studies kind of gave us more support for what we wanted to look at in the horse. So what we did is we took synovial fluid, we collected synovial fluid post-drug administration, and we wanted to look at how the corticosteroids over time potentially affect expression of different genes. So as a starting point, we used an equine microarray, so a gene chip. I know the one I have up here says mouse, but I assure you we used the one for the horse. It is commercially available. And we isolated RNA from the synovial fluid, we put it on this gene chip, and we looked for any changes. And the graph over there, the figure over there on your right, that's called a volcano plot, and that shows the number of genes that were affected by corticosteroid, in our case, by corticosteroid administration. So you can see that each individual dot, there's a lot of dots on here, each individual dot represents a different gene. So what this tells us is corticosteroids affect a lot of genes. Okay, these aren't just inflammatory genes, these are pretty much any gene that's potentially there. I know it's a bit counterintuitive, but the green dots represent down-regulated genes, and the red dots represent up-regulated genes. So we had a lot of genes to choose from, and we certainly weren't going to look at every single one of these. So what we did is we looked at the statistically significant ones. And so now this kind of narrows our field a little bit. You can see that the gray dots, these are genes that weren't statistically significantly different from baseline. So based on these green and red dots, we chose a few specific inflammatory mediators to look at. And we ended up looking at a total of 20 different genes. I'm not going to show you graphs, I promise, for every single gene. I just picked a few that showed specific trends or statistically significant changes, and I was going to go through those. So the first one I have here on the left is a gene called TSG6. This is an anti-inflammatory gene, and we actually see increases in TSG6 in cases of inflammation, in cases of osteoarthritis, and it's thought that this gene is chondroprotective, so it has protective anti-inflammatory effects. Now what we saw was, so the dark black bar represents the treated joint, and then the light bar represents control joints. And I didn't mention this previously, but we did have control animals that didn't receive drug that we collected synovial fluid for comparison to our treated animals. And what you see here with TSG6 is a statistically significant increase in concentrations. I'm not 100% sure what happened there at day 21, but we saw this increase throughout our collection period. Now, there's no studies, at least that I could find in the literature, indicating that corticosteroids specifically increase this protein. But if you look at our controls, you can see that we didn't see an increase. So this kind of suggests, anyways, and obviously further study would be necessary, but suggests that the corticosteroids are potentially increasing expression of this gene. On the next graph over, I have interleukin-1, which is kind of the master cytokine of inflammation, as well as the interleukin-1 receptor. And I took the controls off this just for simplicity's sake, but I can tell you that there was no statistically significant difference in the controls for these two genes. But again, we see decreases, in interleukin-1 at all these different time points. Again, something odd happened to day 14, and I'm not exactly sure what the explanation is for that. And then we saw an initial increase in that interleukin-1 receptor, followed by a subsequent decrease. But I think the main take-home point from both of these graphs is that these actions seem to be prolonged. So it seems like we have a prolonged anti-inflammatory effect, which is a good thing. These are our matrix metalloproteinases, which can cause degradation of different joint components. I have 3 of them listed up here, MMP1, 3, and 9. With MMP1, we really saw an increase, and why that is, I'm not sure. It wasn't a statistically significant increase, but perhaps it was a drug effect. And then with MMP3, we actually see a decrease in expression, so what we would want to see, so potential anti-inflammatory effect. And then MMP9 is a little bit more variable. We see primarily increases. None of these changes were statistically significant, but we do note some trends with these genes. And then lastly, we looked at some of the genes coding for different types of collagen. Now these we did see statistically significant changes in pretty much all 3 of these genes at these different time points. But again, the take-home message from this is that these effects are prolonged. And I have one more graph, and I just threw this up here because I think it's interesting to note the changes that can occur simply from putting a needle in the joint. So this was a separate study. This was actually a pilot study that we did. We collected synovial fluid prior to administering drug, and then we collected it 2 hours, 12 hours, and 48 hours. And what you see, and they're clustered together by gene for this particular graph, but what you see is this increase in these inflammatory biomarkers post-drug administration. So presumably this is due to just simply putting a needle in the joint, injecting the drug, and then collecting collecting samples at subsequent time points. But I think what this shows is that every time we stick a needle in a joint, we're inducing inflammation. And I think it also shows quite nicely that corticosteroids take some time to have an effect. We don't see these levels come back down until at the earliest 12 hours, and then in some cases 48 hours post-administration. So just something to keep in mind every time we inject a joint. All right, so just in summary, from all of these different studies that we've done, we determined that blood corticosteroid concentrations are not necessarily reflective of joint concentrations. So I know I said this earlier, but just because the concentration in the blood falls below that recommended regulatory threshold doesn't mean it's time to necessarily dose again. We showed that the pharmacologic effect is prolonged, and that less frequent administration may be warranted. So just because they're very potent anti-inflammatory agents, we need to also keep in mind that frequent administration can also lead to detrimental effects. Can I just have a few acknowledgments? I already talked about the RMTC and the funding that they provided for this study. Our practitioner study was funded by the Dolly Green Research Foundation. They're very generous and allowed us to do this collaborative study with the Southern California practitioners. And then lastly, the California Horse Racing Board, who kind of subsidizes a lot of my research. And with that, I guess I'll hand it over. Thank you.
Thank you. Our next speaker is Dr. James MacLeod, Professor, Department of Veterinary Sciences, the University of Gluck, University of Kentucky Gluck Equine Research Center. Dr. MacLeod.
Thank you very much, and I'd like to thank the Jockey Club and the Grayson Jockey Club Foundation for the opportunity to speak. I also am really grateful for the data that Dr. Knych showed. I'm going to use my 15 minutes or so to speak more conceptually about intra-articular corticosteroid use, and the data I'll show will be focused on cellular toxicity of articular cartilage cells. So we're all, either through our passion for horses and horse sports medicine or medically interested in synovial joints. They are a remarkable structure that dissipates the large forces placed on the leg of a horse during motion, and also achieve an amazingly low coefficient of friction to facilitate pain-free movement. And that's true for us and true for our racehorses. And when things don't work, we all know them, and so does the horse for sure. So if you look at articular cartilage on the joint surface, that, when it's loaded, the biomechanical properties of that tissue actually facilitate the movement by creating almost hydroplaning between the two surfaces. And the image on the right is histology of articular cartilage, and histologically we define different zones. It actually looks quite similar. But on a cell biology level, on a matrix organization level, it's quite different. And I've just overlaid collagen fiber structure in a two-dimensional form. So at the top, it's horizontal for shear forces, and down near the bottom, it actually goes parallel to the joint surface and anchors into the subchondral bone. Actually, those fibers are making arcs from the subchondral bone and up, but if you cut it in two dimension, it sort of has that format there. And healthy articular cartilage, we're probably also quite familiar with as well. It's a white, glistening, people describe it as a glass-like tissue hyaline cartilage, very smooth. If you look at it histologically, the image right below the horse's knee there, it's a smooth surface. The pink staining is staining of the proteoglycans in cartilage. And when you have an equine athlete or a human athlete, there's this cycle between normal healthy cartilage. A major exercise effort is going to create some level of tissue trauma reflected in inflammation. And just like Dr. Bromledge spoke of the bone and its elastic range yesterday, in the vast majority of cases through rest and sometimes with conservative therapies like cold water or something, that returns to a very normal healthy tissue. We get into problems though if the inflammation is severe or persistent and there isn't time for that recovery of the cartilage tissue, and that can progress to a problem we're also very well familiar with, which would be irreversible joint tissue injury, especially of the articular cartilage and osteoarthritis. and manifested in a breakdown of the cartilage matrix structure, as you can see in the top image. So there, down to the subchondral bone you're looking at. And then the articular surface is roughened, and there's a loss of that matrix protein, proteoglycans, and so the pink staining has been lost. So I would like to follow up on Dr. Knich's data and speak conceptually about our use of intra-articular anti-inflammatory medications, of which corticosteroids are indeed a very wonderful group of drugs and very powerful and therapeutically very nice to have in the arsenal. And if you think conceptually, on the y-axis where you're considering therapeutic activity up to 100%, and on the x-axis the drug concentration, as the drug concentration rises, you'll get the curve of a therapeutic activity which, by common logic, maxes out at 100%. And once you reach 100%, as the concentration increases, you can't get more than 100% therapeutic activity. This is theoretical. In fact, when you get really high levels, you often lose some therapeutic activity, but I left it plateaued at 100%. At the same time, though, for corticosteroids for sure, and in fact almost all drugs, as the concentration levels increase, you also can get side effects that are not the desired therapeutic ones. They're side effects, they're detrimental. And the difference between these two curves is the margin of safety. So obviously you want these two curves separated a long distance far apart so that you have a high margin of safety. If the two curves are very close together, an example we might all be aware of would be chemotherapeutic drugs for cancer. Often you're trying to kill the cancer cells, but the margin of safety for our healthy cells is very close. That's much more problematic. And when you administer medications, if you use a dose that's suboptimal, you're not yet into the therapeutic range. You don't have any toxicity problems, but you also don't have any therapy. You're not getting any of your positive effect. An optimal dose would be in that margin of safety where you're near 100% of your therapeutic activity, but drug toxicity levels are very low. And a toxic dose would be at high levels where in fact you're now on this drug toxicity curve and capturing, to the detriment of your patient, toxic side effects. So as Dr. Knych alluded to, in addition, concurrent in fact, to the wonderful anti-inflammatory properties that corticosteroids have that we would like to access, because if you have severe inflammation, there's going to be production of these protease enzymes that break down proteins in the joint, proteins in the cartilage matrix. That's a bad thing, and we want to, tone down that inflammation. But at the same time, at high and repeated levels, it's been well demonstrated in the literature that you can damage articular cartilage matrix through a downregulation of the synthesis of matrix proteins, and not only in the cartilage and also changes in the subchondral bone. And I would add that the mechanisms of action are largely regulation of gene expression, just like with the inflammatory mediators. Dr. Knych did show a slide with collagen genes, and they were all downregulated. And so that's not the target of therapy, that's a side effect. So that's what causes the loss of matrix protein in the cartilage and problems down the road if you're using doses that cause those effects. The data that I'm going to talk about a little bit is the fact that very high levels of corticosteroids can actually induce cell death in the cartilage cells, so chondrocyte cell death. So here are some data in my lab. These are equine articular cartilage cells grown in culture. So they were isolated from the cartilage matrix, normal cartilage, digested away the matrix proteins, liberated the cells, and put them in culture. And what you can see on the y-axis is the cell viability up to 100%. And what you can see on the x-axis is the concentration. And these are data for methylprednisolone. We also studied betamethasone and triamcinolone. And they were all somewhat similar in that as you increase the concentration, you reached a point where the cells started to die. And you can see different colored curves, and that's a function of how many hours the cells were exposed to the drug across these concentrations. And the data are what you would predict in that a short 3 or 6 hour exposure took higher concentrations to have the same cellular cytotoxicity than 72 hours. So if the cells in the culture medium, had the steroid levels in there, they would start to die at slightly lower concentrations, reflective of the fact that the cells were exposed to the drug longer. But as we all know, joint cartilage cells do not live in tissue culture dishes. They live in this cartilage matrix tissue. And it would be very appropriate to think, well, maybe within the cartilage matrix in the natural in situ microenvironment, the cells are a little more stable. So we address this question by asking the same concentration effects of cartilage explants. This is still tissue culture, but it's little bits of cartilage in explant in the culture dish. In fact, we saw the same effect. The concentrations where the cells started to die were actually very similar to when those cells were dispersed, suggestive of the drugs diffusing into the matrix quite readily and reaching the cells. So then when we think of our patients, though, we have the tissue actually in the animal. We have all the pharmacokinetic variables that were alluded to with distribution and metabolism of the drug. We also have biomechanical loading of the cartilage that can be stimulatory of the cells. So the bottom, a very important question is, what happens when these drugs are used on patients intra-articularly to treat a horse? And of course, when you inject the drug into the joint space, all those tissues are exposed to those pharmacologic levels of drug. And so this is a study we did last fall. It involved 3 commonly used corticosteroids, methylprednisolone or depomedrol, betamethasone, celestone, and triamcinolone Kenalog. The doses we selected were just a single dose level, and we're injecting the fetlock joint, and we went to the high end of recommended doses as in the product literature, as well as the survey actually that Dave Frisbee and Dr. McIlwraith did of practitioners, the levels that some equine practitioners, in fact, the larger parts used in some of these joints, and I'll come back to that in a minute. So 80 milligrams of depomedrol, 12 milligrams of betamethasone, and 9 milligrams of triamcinolone injected into 3 horses in each experimental group. The left fetlocks were treated, both the fore and hind limbs. The right fetlocks on the same horse received injections of saline and were our control. Each horse and each joint received 2 injections. A first injection, a 4-week period of time, 28 days, a second injection, and then the samples were collected at 72 hours. We collected cartilage, discs of cartilage from 2 sites in the fetlock joint, one right where the weight bearing would occur at rest, and one towards the front where the weight bearing would come into play when the fetlock is fully loaded. And then these tissues were trimmed as depicted here. So here's the disc of tissue coming out of the fetlock joint. It actually goes right down to the tide mark. So it's not full thickness as through the calcified cartilage, it's down to that calcified cartilage. You get a disc of cartilage, and then that's trimmed. The staining of the tissue happens next in the little dish at the lower right, and then the cells are analyzed by confocal microscopy. And the confocal scope actually can look at a deep layer of the tissue, so it's not right at the cut surfaces. And the fluorescent probes, if the cells are alive, the cells are green, and if the cells are red, they've died. And somewhat to my surprise, which is a little bit hard to perceive on this, in this light on the screen, but we did see in vivo cytotoxicity at these doses, at high-end doses recommended in the product literature and used clinically. So on the control side here, you see all the green dots are the live green cells. This is the articular surface. And I think you can perceive the increased level of red dots in here. Those are cells in the horse's joint that have actually, cartilage cells, cells we really want, that have been killed by these 2 doses of corticosteroids. And the data analysis is continuing in the different sites in the forelimb and hindlimb, but I'll show you the summary data. We actually saw this effect in all 3 drug groups where the treated side had an increased level of chondrocyte cytotoxicity. So just to summarize, I think these data suggest that if we administer repeated levels of corticosteroids in the joint, especially at the high end of recommended doses, and I know many practitioners and many owners are aware that to use lower doses, that there's literature out there already supporting this and recommendations that have been made. Partly the issue of understanding and communication challenges still exist, and so there still is a population of practitioners and perhaps certain traditions in our equine sports medicine world where multiple joints are injected repeatedly at high levels. I think we're shifting our curve to the right, where we're picking up this drug toxicity potential. We can't get any more therapeutic activity. The data suggests that therapeutic curve is at substantial lower doses and fully accessible to us. And I think we have the potential, actually, in addition to the matrix changes, to actually cause chondrocyte cell death. And I think we as an industry and as veterinarians and horse enthusiasts would be well served to reflect on levels of corticosteroids and how they're administered to optimize that efficacy safety profile. We certainly want to have them available to control inflammation. They're very powerful and very good drugs for that purpose, but we certainly we want to minimize the potential toxic side effects. And with that, I will acknowledge 2 people. I've shown you data primarily from the PhD thesis research of a student in my lab, Wenying Zhu, and Emma Adams helped with the in vivo study I just showed you. Chris Johnson, veterinarian surgeon here in town, helped with our analysis to make sure those 9 horses had normal, healthy joints and assessed the radiographs with us. I'd also like to acknowledge that partially this work was funded by the Kentucky Racing Commission through their Equine Drug Research Council. I've also supported our horse work in the lab from the Grace and Jockey Club Foundation and Morris Animal. And if I could make a plug to the earlier talks, several people mentioned just how valuable not only communication was, but information and knowledge. And that knowledge and our ability to move forward comes from research. And so, yes, we can benefit and grow from the research today, but there are a lot of questions left, and we really do need to continue to invest in new discovery, research, and experimental biology if we want to move these things forward. Otherwise, we spend our time speculating and arguing and giving our opinion, but if we really want to move forward, we're going to need the data, and research costs money, so we have to be willing to invest in that. Thank you.
Thank you, Dr. MacLeod. Next, we have Dr. Wayne McIlwraith. He is Professor of Surgery and Director of the Gail Holmes Equine Orthopedic Research Center in the Department of Clinical Sciences at the College of Veterinary Medicine and Biomedical Sciences at Colorado State University. Dr. McIlwraith.
Thanks, Ed, and thanks for the invitation to be here. This is our 5th welfare and safety of the Racehorse Summit, and I've been here at every one, and I think this one's really exciting in terms of big changes, I think, in transparency and really having positive moves forward. Jamie said green button. Okay, so I'm going to go through, this will be a summary. The 2 previous speakers have really helped clarify a couple of areas that are important and controversial. So I wanted to go through, I think the big issues as I see it are indications and beneficial effects, side effects and risks, and then where the new regulations are taking us. And there's 3 phases here. We've already seen the horror and rejection from trainers and veterinarians, or veterinarians and trainers, getting over it and reevaluating options. And we've already had some speakers express positive signs that this is already taking place, and improvement in practice, which is the ultimate goal. So, as has been said by both previous speakers, traumatic arthritis and osteoarthritis is a huge problem in the racehorse. Synovitis, which is inflammation of the membrane, and capsulitis, which is inflammation of the capsule, need to be treated symptomatically by the racetrack veterinarian. They're part and parcel of cyclic trauma. Preservation of articular cartilage and avoidance of deleterious side effects is critical, and maintaining and restoring homeostasis is a critical part. And Dr. MacLeod already showed that the red staining proteoglycans, and these are represented by the bristle brush molecules on the right-hand slide, that together with the collagen framework make up this strong structure that's very resilient. But if we have breakdown of those products, we get this. So this is showing the 2 main issues, or the 2 basic pathobiologic processes that need to be considered in joint disease: inflammation of the synovial membrane. As can be seen on that arthroscopic view, the synovial membrane secretes the joint fluid, but on the other hand, it quickly reacts to trauma. And if we continue to have those enzymes produced and various mediators that have already been discussed, we can get loss of articular cartilage. And that shows histologically as fibrillation, and there's other changes such as accumulation of, we actually get replication of chondrocytes, which is a rather failed attempt to repair. So I like to divide the osteoarthritis syndrome into various stages. We start off with stage 1, which is hopefully what we're most commonly treating, synovitis and no morphologic change in the cartilage. Phase 2, where the synovitis may be less acute, but we're starting to get change in the cartilage in the bottom of that diagram. I haven't mastered the pointer here yet. Oh, I got to point to the slide. That's a good point. I'm used to having an arrow on my laptop. Stage 3, synovitis is more chronic. You start getting progressive loss, and then this is the full thickness loss of articular cartilage that you can see over here on the right-hand lower slide. It's not showing up too well. The owner and the trainer may have different wishes or different outcome desires compared to the veterinarian, but if the veterinarian looks after those processes, which is to try and prevent and stop the injury, stop the progressive loss of cartilage, then you get the other effect of long-term use of the horse and soundness. So this is an animation showing what happens with synovitis and capsulitis. And of course, it's reviewing stuff that you've heard before from Dr. Knych, but we've got cells coming from the vessels through, getting produced by the synoviocytes, which are the cells lining the synovial membrane, releasing not only cells, but also various mediators into the joint. They then go to the articular cartilage, and this is a diagram. The pink things are chondrocytes that Dr. MacLeod's been talking about. In the background, we see the collagen. I'll come back to that. This is sort of the top of the cascade. There's a product called interleukin-1, and there was quite a bit of that on Dr. Knich's slides. And we've sort of pretty well proven that that's the real bad guy at the top of the cascade. So it latches onto a receptor on the cell, and then various signaling factors go and get to the nucleus, and this is where the gene expression changes occur. This is a sort of animation of gene expression changes, and Dr. Knych showed both upregulation of some things and downregulation of some things. Well, here what we're getting is generally an upregulation of a number of products coming out of the endoplasmic reticulum and going into the cartilage matrix, which is the stuff that is the majority of the cartilage. And we have these various products. PG2, you also might have noticed some slides showing COX-2. That's one of the forms of cyclooxygenase, the bad one that produces PG2, a prostaglandin. We've got metalloproteinases, aggrecanase, MMPs 1 and 13. And between those products, they can break down both the proteoglycan molecule. So this is the same thing that was staining pink in Dr. MacLeod's slide. These bristle brush type red molecules give the compressive strength to the cartilage, and then the collagen, these stripy blue things, provide the compressive strength. So aggrecanase, for example, and MMP3, it's now considered aggrecanase as the real bad guy, break down the proteoglycan molecules, so you're going to lose your compressive strength, and then collagen gets broken down by MMPs 1 and 3. And so these have provided targets, and we'll talk about biologic therapy later. The important thing is if that process carries on, we get loss of and breakdown, morphologic change in the articular cartilage. So what are our choices? We certainly have multiple targets, but multiple options as well. However, the efficacies are different. And so I'm highlighting corticosteroids, which is obviously the subject of this. And corticosteroids can handle many of these processes. However, there's two big issues. They're potent and long-acting. And the gene expression changes shown by Dr. Knych are a good example of that. The side effects, there are side effects, but there's differences between products. And so we'll talk about that just a little. So in summary, these were the original intra-articular therapy. However, there was a lot of untoward effects that were generalized in older times, and some of them are fictitious. The commonly used ones have been carefully evaluated, as you saw in the previous two talks. And at CSU, we did a lot of work with an in vivo model of osteoarthritis, with the hypothesis that do the beneficial effects of corticosteroids outweigh the deleterious effects? And there's a dose issue is huge, and we'll come back to that in a minute. This is a review that I wrote a few years ago, basically that has all this material in there. I'll quickly touch on some parts, but there needs to be a point where therapy ends and competition begins. So this is how I had awakening. So I did my veterinary degree in New Zealand, but I don't think it was any different in veterinary degrees in the States as far as how much was talked about corticosteroids. Corticosteroids were bad. That lecture was very quick. But this was a great example of clinical observation. In 1983, I started doing arthroscopic surgery at a hospital across the road from Los Alamitos, invited by Dr. Nancy Goodman on the left, and then Dr. Bart Baker. It was his clinic. His son, Vince Baker, has a big practice in Southern California now. And I was scoping these joints and presuming that they'd never had any corticosteroids. And then I found out that they'd had lots of it. Well, they'd had frequent injections, but with this particular product. And we'll have to come back and tie this up a little bit later, but it seemed like there were joints that had a history of multiple injections of betamethasone esters. It was then called Betavet Soluspan. It's now available as Celestone Soluspan. So I went back to CSU to our lab, which was rather small at that time, and we did a study where we put Betavet Soluspan at 14 days and 35 days, 2.5 mils into some horses. And we used the other joint as a control. We found that we had some systemic effects, but the important thing was we had 4 groups, because the old dogma was corticosteroids are bad, but if you have to use them, don't exercise the horse. Well, we disproved both those points in the case of Celestone, because we caused no harm to the cartilage, and the exercise group, in other words, the group that got betamethasone and had exercise on a treadmill, had the highest concentration of glycosaminoglycan. That's not to say that they were making that better, but they were protecting. So we then went on to some more controlled studies, and we being Chris Kowchak on the left and Dave Frisbee on the right, who have been with me for a long time, working together. So this was just a brief review of, we looked at triamcinolone, we looked at methylprednisolone acetate or depomedrol. Depomedrol, first of all, this is sort of an in vivo demonstration of what Dr. Knych was talking about, the long-term effects. Even though we injected them at 14 and 28 days, you can see that we still had lower PG2 concentrations, which is a very good marker of inflammation for us at the end of the study at 70 days. And we also had still significant decrease in inflammation in the synovial membrane, judged by those 2 parameters. And modified Mankin scores, however, this is the bad news. Mankin score is just an index of cartilage injury or cartilage degradation, and it was significantly increased at day 70. So this is sort of an example of 2 main things. One is that the long-term effects of them therapeutically, so you don't need them as often, and it's also a clarification of depomedrol and its deleterious effects on the cartilage. And this is just an example. Yes, we had decreased inflammation judged by PG2, but we also had increased articular cartilage degradation. On the other hand, when we looked at triamcinolone, and the dose in this study was actually 12 milligrams, so the same as the level that Dr. MacLeod did in his study, we had separate horses because we do get some crossover effects systemically, or we've seen those. Anyway, in each case, we got significant reduction in lameness, significant reduction in total protein and HA in the synovial fluid, as well as glycosaminoglycan concentration, less cell infiltration, intimal hyperplasia, these inflammation in the membrane, and modified Mankin scores, in other words, that index of cartilage degradation, we have a scoring system for that, were better in both. That TATX is when the triamcinolone was injected in the same joint, and the TACNT means that it was injected in the joint that didn't have a chip fragment. We have a chip fragment in one joint, And even though we put it in the opposite joint, we still had a therapeutic effect. So, lameness examination significantly decreased. Triamcinolone had no negative effects on the cartilage. You can see that the Mankin score is closed. Now, we still need to do work on dose. And I think in vitro extrapolation needs to be validated. But I think, you know, the slides that Dr. MacLeod showed, we're limited. We've tested one dose in the in vivo model. It's not only expensive, but obviously it uses horses. But the message to use lower dose is getting out there, and I think it's already being practiced by a lot of veterinarians. Many people no longer use the dose that they used 10 years ago or 5 years ago or even 2 years ago. There has been a history of change and adaptation, but this study, which Dr. MacLeod mentioned before on current joint therapy usage that we did as a survey, we surveyed 1,200 AAP members, or they're the ones that gave us responses. And this is the interesting thing, and I'm sorry I haven't highlighted this, but if you look there, triamcinolone acetonide compared to methylprednisolone acetate in high motion joints was used by racetrack veterinarians less, whereas sport horse veterinarians tended to use it more. In other words, there was still hanging on at this stage to methylprednisolone acetate. Now, the work of Dr. Knych and the RMTC recommended thresholds are going to fix that, but it just goes back to the point. We have been on a campaign for a long time that methylprednisolone is bad based on our research. And now it's sort of, it's already been accepted by a number of veterinarians before this new RMTC work was done, but it has helped a lot now to have those limitations recognized. What about the association with catastrophic injury? And I think it's important here. There's been an association, but the cause has not been shown. There's been plenty of anecdotal opinions, but there has been a study in Australia recently. I haven't got the reference up here, but they showed that the injury rate was higher in horses that have been injected with corticosteroids. But obviously, there's another factor there, and I think the first speaker yesterday made a really nice point in pointing out the difference between association and cause. And this is the case here because obviously the horses that were getting injected with corticosteroids had a clinical problem as opposed to the horses that weren't. What work has been done is Rachel Murray, who's now in Newmarket, she did some work on looking at methylprednisolone acetate on bone. So I've just talked negatively about MPA in cartilage, but it does not have a negative effect on bone, or at least in this study. And there was also no effect of triamcinolone on the bone, looking at the bone in a study that we did at CSU that's referenced below. That slide below looks at microdamage, and Dr. Bramlage gave a great talk yesterday about early change in the bone. And this is what we see with basic Fuchsin stain, but we have to bulk stain it to differentiate from just cutting the bone and creating artifactual fractures. But what we've got there with the increased staining, cartilages above and bones below, is that we're getting microdamage, and obviously it's not practical to diagnose it on a lump of bone on the post-mortem table, but this is where the biomarkers, which is not the subject today, but early diagnosis, we're making progress, but it still needs to be better. We've got to find the horses at risk. Anyway, there is no evidence at the moment that corticosteroids cause, but certainly there's been associations made with the study I mentioned before. This is a slide that I received from Dr. Rick Arthur, which makes a huge point. This is a horse that passed the pre-race exam as sound, but it had 2 NSAIDs and 4 corticosteroid injections within 72 hours of the race. And you can see the damage, and Dr. Bramlage talked about the early change here, but we've got a condylar fracture right through a palmar osteochondral defect. Subchondral bone disease, as I mentioned before, precedes articular fractures, and so we've got to be cognizant of that. But it's another challenge, and it's not a separate issue, but it's certainly separate from the point of view of just blaming the corticosteroids. So attention has increased a lot, and there's been a number which I'll just flick through in the interest of time. The AAP white paper in 2010 recognized that it's very important that we need, based on the parimutuel environment, that the practice of veterinary medicine needs to fit within it. But from a medical point, entry-driven procedures are generally not in the best interest of the horse, and this has been discussed before, but the injection of corticosteroids close to time, because that's what the business model is when a blue-collar horse, that was the term used yesterday, is in and requires injection, or is considered to require injection. So there's been more recent developments with the examination by the RMTC, the research on thresholds done at a number of universities, but you've had the work out of California being presented earlier by Dr. Knych, and recommendations that were developed during an RMTC AAP-hosted corticosteroids expert conference, and this was that conference, and these were some of the comments in the press release that came out of it. And the bottom line here is that we need sufficient time between treatment and racing to allow the veterinarian to evaluate the effects of each treatment. And this work has also been done by Dr. Knych and shown by Dr. Knych here is the important bottom line. These are the thresholds, and so then they've gone back in that study in California and given good guidelines. We've had a grace period to identify how much we can give and how much of what particular corticosteroid can be given. So these are the recommendations of that panel, that the corticosteroid threshold should remain as recommended by the RMTC and enacted by the ARCI. The recommendations will change the use. This is a slide I used when I presented at the AAP in December to veterinarians. It'll certainly change the use of corticosteroids overall, but particularly with methylpenicillin acetate or depomedrol. Yes, the cheese has been moved, alluding to that book, but adaptation is occurring, and this is the study that Dr. Knych has already presented, but very, very useful information, and certainly identifying the limits to some corticosteroids and the dose. So just briefly, some other options which I presented when we were talking to veterinarians about what they were. I've just highlighted a couple. I'm going to talk about hyaluronic acid as well as anti-cytokine therapy with IRAP. The latter has been commonly, has increased its use greatly where corticosteroid thresholds are more restrictive, such as Europe, New Zealand, and Australia. And of course, so just briefly, hyaluronan has commonly been given along with corticosteroids. This was some work we did in the same chip fragment model where we showed that we didn't significantly decrease effusion, so we didn't have the dramatic anti-inflammatory effect of corticosteroids, but we certainly had less cartilage fibrillation, which is a cardinal sign of cartilage breakdown, cartilage degradation. So we could classify HA as a disease-modifying osteoarthritic drug. And also in some other work that's published in the human literature, arthritis and rheumatism, where I gave fluids to Dr. Bob Saar, who's an expert on joint lubrication at UC San Diego. And what we showed was that in acute joints, so these were fresh chip fragments, fresh fractures, the fluids had all lubrication ability gone. And Dr. MacLeod talked about that briefly in his seminar. And we found that we could totally restore that lubrication function with addition of HA. On the other hand, when I gave him fluid from chronic joints, they could not show the same. I should say, Dr. Antonacci, who did her PhD on this project, a grad student of Dr. Saar's, we didn't get the same lubrication change. The joint had started to restore lubricating function, but it did not respond to HA anymore. So there is a role for HA. On the other hand, not to put a wet blanket on it, but this is a really interesting study that's just been published in Osteoarthritis and Cartilage in human literature. These authors are the gurus of osteoarthritis in humans. And it was a global study, and what they did is they did meta-analyses and systematic reviews, and then they got together and argued the point. And because what they wanted to do was what was the evidence for value in various treatments. And there was a whole lot of treatments that they looked at, and these are just on the slide. But focusing on knee osteoarthritis in humans, this was the point. So they came up with scoring for appropriate and with beneficial and harmful. So red's risk factors and harmful, and blue is beneficial effects. And this is with corticosteroids. And as you can see down the right, for the first all 4 conditions, intra-articular corticosteroids were appropriate medication. On the other hand, with hyaluronic acid, which has been a more recent treatment for osteoarthritis in humans, you can see that they were uncertain for 2 categories of OA, knee OA, in both categories, whether they had comorbidities or not, and there were more negatives with it. So apparently I was talking to someone who was on that panel just recently, and the drug companies are already upset with them, but particularly the ones making hyaluronan products. But just to make the point that we have other options, but we've got to be realistic as to their value compared to corticosteroids. Intra-articular Equine we've similarly shown to be a potent anti-inflammatory. So lastly, the biologic therapies, and this is a modification, this is the Frisbee modification of a slide I've used a long time, or I produced a long time ago. Interleukin-1 is bad, IL-1RA is good, and I sort of showed that in the animation. So what are our options? Well, we've done a lot of work with gene therapy. It's not out in the practical arena, so I just want to use it, show it to you to make the point that this study with gene therapy, we put an interleukin-1 receptor antagonist in with an adenoviral vector, proved that if you can inhibit interleukin-1, you can make a huge difference to osteoarthritis. Because the horse above, in the top line is the control, placebo, saline. The bottom one is that cartilage, very similar to the slide you saw from Dr. MacLeod before, where we've restored or we've maintained our saffron and O staining, our proteoglycan staining, with a single injection of the gene for interleukin-1 receptor antagonist, the natural antagonist. So this has led to the development of these products. Well, really simultaneously, a German MD was developing the Orthokine system, and this is developed into the IRAP systems that are available in human. They managed to trademark IRAP as interleukin-1 receptor antagonist protein. And so just briefly, there's quite a lot of work. This syringe, in the case of IRAP1, in the other one, it's a different container. It's got the magic beads, as Dr. Bramlage has coined the term. But you incubate blood from the same horse for 24 hours with the beads, take it out of the incubator, centrifuge it, and then you got enough for 3 to 5 injections, depending on what size joint you're using. So there's been multiple reviews, and the one thing I'm just going to focus on, interleukin-1, we do show that we've got an increase in production of IL-1RA compared to interleukin-1. We've also shown that if we compare the 2 products, this has been published, but we had higher levels of IL-1 beta, which is the bad guy, higher levels of TNF-alpha, which is another bad guy. Sort of we're still arguing how important it is in osteoarthritis, but it's certainly the huge one in rheumatoid arthritis in humans, which is a very strong inflammatory problem. And we also produce growth factors, good growth factors that are positive for the joint. So this is emerging, but I just want to make the point, we do have alternatives, but we've got to put them up against the corticosteroids. There's other products will emerge, but we will need validation. This product on the left is an example of something without any validation, but is being used quite a lot. So my take-home message is we can still use corticosteroids, but selection of product and dose is important. It's the best treatment for the horse is the priority. Always consider the inside of the joint and those processes that all 3 of us have talked about. There are other options, but selection should be evidence-based, and progress here can enhance credibility and understanding. Thank you.
We have time for a few questions and still keep to our schedule.
Hey, I want to thank you all for a great set of talks. Those were wonderful. So I think we've gotten to the point now, and the question that I have is, do you feel judicious use of us getting better at understanding that is occurring with corticosteroids, or do you think we still have to lower the dose and get better at that at the track? I still think people need to know to lower the dose and it has an extended time. What's your feeling to that? For judicious use.
Yeah, I'd agree. I didn't want to put everything in there, but there's a veterinarian who's a pretty global practitioner, John McVeigh. He actually talked at the Jockey Club Summit a few years ago. His dose on triamcinolone is 2 milligrams, and he swears he gets the same results. So it gets back to the point I made before. We've only tested one dose in our in vivo model of OA. And, I think stuff that Heather and Jamie are bringing up is huge in this whole thing. So, yes, striving for lower doses, but that's what the new thresholds is going to help. Because people are now playing with it, particularly when they want to do multiple joints.
Do you guys have any theories as to the mechanism of toxicity when the chondrocytes die? Any data or theories that tells why, when you get to a certain level with the corticosteroids, it's pretty uniform death, as Jamie showed?
No.
That's not good enough.
I think it's, our assessment is that it's not anything like an apoptotic mechanism, it's a necrosis. I think there is understanding, especially arms of steroid use or arms of steroid mechanism of anti-inflammatory activity tend to be more binding of transcription factors that activate pro-inflammatory genes, whereas the downregulation of the matrix proteins are directed interactions with glucocorticoid response elements on the DNA. I think that there are new molecules being developed by the chemists that separate those arms and are a much more targeted therapy. I think those have potential as well. So rather than the broad impact on so many genes as were apparent in the transcriptional profiling data, more targeted activities. And I think as we dissect those things, then there's hope to address that. I don't know if you have any.
No, I agree with all that.
Joel Spade, Texas Racing Commission. I am not a vet, so you'll have to excuse my naive question. But is there any efficacy studies taking place on regenerative injection therapy like prolotherapy, which they're using on humans? Because I've found that certain humans that have had prolotherapy, it has definitely rejuvenated their ability to continue physical activity.
Yeah, I'm not aware, but I don't know, Dr. McIlwraith, do you have?
Now, sorry. There's been a little bit done anecdotally, but we've never looked at it, and no one has that I'm aware of in the horse. Sorry.
We can take one more question, please.
Yeah, I'm curious, Dr. Knych, do you think you can use gene expression for a dose response study for these intraarticular corticosteroids, or is that a little bit too premature at this time?
I think what we know right now, it's probably a little premature. There's a lot of work, I think, left to be done. I didn't really mention this in my presentation, but the horses that we used for our gene expression were horses that were just exercised. We didn't, induce any inflammation in those horses, so there's no, acute inflammatory response. But certainly that's something we're looking to do. But that might give us a few more answers into that as well. But certainly, at this point, a little bit premature, I think.
Okay, last question. Sorry.
The question I have is, it appears that part of steroids or steroid use is to manage blindness and not cure it. Is that a fair assessment?
Is that the end of your question?
Well, I guess what I'm just extrapolating from that, assuming that horses are treated over and over again with steroids to either control or cure lameness, when do you find another job for the horse?
Well, you're making a lot of presumptions there. The first thing is that, no, they have disease-modifying effects. I mentioned that briefly. We've demonstrated that with triamcinolone. But that's why we're going on to the biologic therapies. If we can find something that's better and is kinder, then we should. But the other thing is, both from the in vivo work that I showed as well as the work that Dr. Knych presented, these are long-acting products. They don't need to be injected nearly as often as some people presume. On the other hand, many of these horses are treated on a one-time basis or maybe twice. They're not treated, the impression that all horses get multiple injections forever throughout their career, you can't generalize that way.
Okay, thank to all our speakers.